Thank you for your kind words. So we go to a simpler topic, amblyopia management, which I'm sorry, my video is on. So amblyopia management, as pediatric ophthalmologists and sometimes even general practitioners, we cannot escape managing amblyopia in children. So what is amblyopia? So it's a unilateral or bilateral subnormal vision. We have to most of the time find an attributable cause for it. There should be ideally no structural or organic pathology and susceptible age. Younger age, you can't diagnose an amblyopia onset after the age of 8 or 9. And response to treatment. Sometimes retrospectively, you can give a trial of treatment, and if it responds, you can conclude that there was amblyopia, along if there are multiple other factors also, as well. So what causes amblyopia? So causes is uncorrected blurred vision. Is the commonest cause. Ocular misalignment, that is strabismus, subnormal or absent stimulus, and sometimes the combination. Sometimes, most of the time, many times there is a combination of all the above. So based on these causes, there are types of amblyopia: refractive amblyopia, strabismic, stimulus deprivation amblyopia, and combined mechanism amblyopia. So what are the types of amblyopia? Refractive amblyopia, like high refractive errors, can be bilateral, and it is called ametropic amblyopia. So hypermetropia is more amblyogenic. More than 4 diopters when present can be amblyogenic if it's bilateral as well. High astigmatism of more than 3 diopters is highly amblyogenic. Significant anisometropia is a cause like myopia, more than 3 diopters between the eyes, difference between the eyes 3 diopters. Astigmatism and hyperopia, more than 1.5 diopter between the eyes, can be amblyogenic. So refractive amblyopia, how it works: when it is high refractive error in both eyes, there is a constant bilateral image blur which causes the amblyopia. And when it is unilateral or anisometropic, there is an interocular competition or inhibition which is the cause for the subnormal vision. So strabismic amblyopia, there is constant misalignment is the cause. The earlier the onset of the strabismus, the denser and higher the chance of amblyopia caused because of it. And esotropias are more associated, more amblyogenic than exotropias and other ocular deviations. So how a strabismus leads to amblyopia? It is strabismus causing confusion, suppression, which is an adaptation, which if left untreated leads to amblyopia. Otherwise, strabismus can cause a lack of foveal stimulation and again causing amblyopia. So these are the 2 ways it can cause amblyopia. So stimulus deprivation amblyopia is the 3rd type of amblyopia. So any hindrance to the stimulus, like amblyopia ex anopsia, anything which interferes with light entering into the eye directly can cause amblyopia, starting from ptosis, corneal opacity, cataract, commonest cause of stimulus deprivation amblyopia, vitreous hemorrhage. So here the mechanism how amblyopia develops is there is a total lack of pattern stimulus, and this carries the worst prognosis, especially when it is unilateral. So we coming to management. So how do we manage? So before we know how to manage, we need to know how they present. So many times they can present asymptomatically, accidentally discovered by in childhood. Lucky if we are when we just diagnosed in a childhood by accidentally covering one eye and you realize that the other eye has poor vision. Eye screening, very important. That is why schools advocate eye screening as early as possible. That is one way of detecting amblyopia. The presence of a strabismus should prompt us to diagnose and detect amblyopia. And sometimes missed, when it is missed grossly, when the patient is asymptomatic without any obvious external evidence, as late as during job interviews, amblyopia can be first detected. And how to diagnose? So visual acuity with using age-appropriate tests, fixation pattern when there is a presence of strabismus, cycloplegic refraction to see anisometropia or ametropia, and binocular tests like 4-prism base out test, 10-prism base down test, and stereopsis tests, and of course cover test and alternate cover test. So all these tests help us to diagnose, detect amblyopia, and of course a thorough slit lamp and fundus examination to rule out other causes of visual impairment. So management. So how do we manage amblyopia? So first, if we find a cause, the first is to manage the cause and then treat the amblyopia as such. So to manage the cause, the idea is to give optimal retinal image clarity. So when there is a refractive error that is the cause, the full cycloplegic refractive correction is the first mode of treatment. And whenever there is strabismus, you have to manage the strabismus. But ideally here, strabismus management has to follow amblyopia treatment, and clearing media opacity is this, followed by rigorous amblyopia treatment is how we treat the cause. Then you stimulate the cortex. The management of amblyopia as such involves stimulating the cortex. Once the cause is being addressed, then we occlude the normal eye or penalize the normal eye and stimulate the cortex of the abnormal or subnormal vision eye and improve the vision. So how do we manage a refractive amblyopia? Amblyopia caused by refractive error. So there is a concept called refractive adaptation, where we use only refractive correction as a management of amblyopia, especially when there is ametropia or bilateral subnormal but equal vision, and minimal anisometropia, when invariably the vision improves just by the use of glasses. So we can try this as a mode of treatment for from the age of 3 to 8 years of age, and for 6 to 8 weeks. Beyond 8 weeks, if the visual acuity, especially in anisometropia, is not improving just with the use of glasses, we have to switch to other mode of amblyopia management. So in strabismus management, ideal, you have to manage the strabismus only after amblyopia treatment, and clearing media opacity, the younger the age, the earlier the management, and unilateral like an emergency. So once we clear the media opacity, immediately the amblyopia management should start. So in this situation, if we see, this is a child with a vision of 6/24 N8. There is a -3 astigmatism in that eye at 150 degrees, and there is an exotropia, and there is an obvious cataract. So what is the cause here for the subnormal vision? So it's probably a combination of all the above. So there is exotropia, there is cataract, there is an anisometropia. So here, this is a typical case of combined mechanism amblyopia. So you treat one by one. Since the cataract is not exactly in the center, you can first try correcting the refractive error and do amblyopia treatment. And if vision doesn't improve beyond a certain level, then you plan a cataract surgery and continue amblyopia management. So how do we treat amblyopia? So to treat amblyopia, we need to know how dense the amblyopia is. So based on visual acuity of the worst eye, mild means better than 6/12 vision, moderate is 6/12, 6/80 to 6/24, and severe is worse than 6/36. And perception of light or no perception of light is never because of amblyopia. We should be very sure that we have to find some other cause. So there are a lot of ways to do occlusion therapy, depending on the convenience, depending on, you always have to demonstrate how to do occlusion therapy before you just not just verbally tell. The gold standard treatment for unilateral amblyopia. So complete occlusion has better effect, and part-time occlusion has become the gold standard rather than full-time occlusion. So age proportionate occlusion is indicated, and density of amblyopia determines how many hours of occlusion is indicated. And patching is the form of part-time occlusion. Occlusion protocol for infants, best avoided before the fixation develops. So after 4 months, when there is, especially when there is strabismus, you can wait up to 4 months to start your occlusion protocol. 20% of waking hours only. Very close follow-up is necessary because fixation switch can easily occur, and reverse amblyopia is very common in very small infants. And by ATS study, which all pediatric ophthalmologists now follow, for moderate amblyopia, 2 hours per day patching seems to work very effectively. Even for severe amblyopia, initially we can start with 2 hours, and if it doesn't improve, can raise it to 6 hours per day. And children older than 6, like 7 to 12, patching is effective even if previously attempted but discontinued. And older children, even after up to 17 years, patching is effective, but only when previously not attempted. And penalization is another mode of treatment. It is useful in children from 3 to 7 years of age. Atropine is used at 1% to the vector eye. It is effective in moderate amblyopia only. And it is proved that even weakened atropine is as effective as daily use atropine. It is not effective in very severe amblyopia, and you have to watch for side effects of atropine when you give penalization as a treatment. So follow-up protocol, when you follow up children with amblyopia every 3 months if they are young, every visit you have to assess compliance by questioning, and by questioning directly sometimes the patient. Visual acuity has to be measured every time for distance as well as near, because near improves faster. And refraction every 6 months at least, to no change in the refraction. Binocular vision has to be measured whenever indicated because binocular vision is also improved in amblyopia treated. An improvement in the alignment and sometimes the control if the deviation of the strabismus was intermittent. So the goal and end point would be ideally equal vision. So stable vision for 2 consecutive visits with good compliance of patching after the age of 8, at least 2 years of patching if younger than 8 years of age. No further improvement after increasing the dose of patching. We can decide to stop. Alternation of strabismus in a child with strabismus is a good indication that patching can be discontinued and surgical correction can be started. And when we stop, we generally taper rather than abruptly stopping. So what is there a failure of treatment? It's a very, very common failure of treatment is very common, especially because of compliance. The treatment, because it is a very long duration of treatment, compliance becomes a challenge. It can be a stigma because we patch the eye and children do not go out, they cannot play and all that. And side effects to patching sometimes can be a limiting factor. So we have to include parents and make it like a inclusive treatment. And positive reinforcement can be a very good option to improve compliance. Refractory amblyopia, sometimes amblyopia refuses to improve in especially conditions with unilateral dense media opacities, cataracts, even if we operate at a very young age. And sometimes there can be very subtle organic issues like macular pathology and optic nerve issues. The newer modalities nowadays are coming, which are vision therapy, computer-based programs, prisms, Virgin's activities, anti-suppression exercises, accommodation exercises. So many of this are based on binocular therapies rather than uniocular therapy. Like there is a method called anaglyphic method using 2 colored glasses. The amblyopic eye has to see one, and these are helpful in children who have not shown improvement or children who do not comply with patching treatment. Another, which is a current treatment modality, which is picking up, is the virtual reality based treatment. This is a very interactive treatment, so children are very compliant, and but the equipment is very elaborate, so it is most of the time done in the hospital setting only. So ideally, prevention is a better option. So eye exam from infancy is advocated. Screening, the aim of screening is to prevent amblyopia, identifying amblyogenic factors.
It's 12 minutes.
I'm sorry, treating high-risk patients, positive family history, etc. So to summarize, amblyopia is extremely common, but preventable and treatable if detected in early stages. I'm so sorry. Thank you.